Junior doctors are often frustrated about the audit process, partly because they have very short rotation cycles, so often they'll be in a post for a number of months and then move on, and partly because they have seen that they're able to measure a problem and identify a problem, but not take action to change it.
You present your findings, but your recommendations don't necessarily get introduced, and then you've moved on by the time there's a chance to re-audit and see whether there's been any positive changes, unfortunately.
Learning to make a difference is all about how we can engage trainees in learning about and developing new skills in quality improvement, and how they can then apply that in practice at the front line and make a real difference to their patient care.
So I became involved in Learning to Make a Difference as an ST2 in core medical training in the Oxford Deanery, and the whole concept was introduced to our year group of core medical trainees in the hospital, and we were all quite engaged and quite enthusiastic about doing something different from audit. At that particular time I was actually working in the stroke unit, and my goal was to develop a tool to assess all acute stroke patients for anxiety and depression. The fact that it was short and simple and could be completed in an adequate time frame made it really suitable for quality improvement. Depression, which I think it might suggest, and I'd like our neuropsychologist to come and have a chat with you to see if we can address that.
There were 5 deaneries involved in the pilot and 61 trainees, and they were able to achieve their quality improvement projects within a 4 to 6 month training period. What we wanted to do was to try and have some form of methodology that could be used in a very simple, structured way so that they could complete and testing out change within that time period.
In stroke medicine, it's really important to involve the multidisciplinary team because we all work together really closely. So I involved the occupational therapist, the physiotherapist and our ward neuropsychologist, obviously as well as a stroke consultant. And we came up with a couple of assessments to try out on the patients in the stroke unit just to see if it worked. Because ultimately it was going to be the occupational therapist that were going to take on the role of assessing the patients for anxiety and depression. So together we came up with a flow chart to follow depending on what impairment the patient had from their stroke. A new performer and a flow chart into the department for the multidisciplinary team to follow to make sure the patients...
We've had junior doctors looking at prescribing processes. We've had them looking at delays in patients getting blood tests, for example, delays in patients getting antibiotics. And we've taught them to go and map that process, all the different stages and all the different factors that are involved in that. And then we've given them some skills to think about how that might be changed.
By introducing kind of a new performer and a flow chart, it meant that after 4 months, all patients were being assessed for anxiety and depression within 5 days of admission, which met the NICE guidelines and also meant the stroke unit was scoring really highly on their audit. Because if patients are suffering from anxiety and depression, they struggle to engage in their rehabilitation, which is a really important part of stroke. So overall, hopefully the patients got a better experience. They had spent less time in hospital and had more successful rehabilitation. They're quite anxious. We just like to pick these things up so we can address them. Okay. So just try and...
The real difference here was about how enthused the trainees have been about doing quality improvement projects.
It's much more satisfying for them when they identify a problem to be given permission and then given skills to go and solve that problem and to see a real result from that.
It was nice to feel you owned the project. I think you became more enthusiastic about it and you wanted to see it through and you wanted to have good outcomes.
It went through to the other trainees who were of other specialties and grades and the multidisciplinary teams around them. This meant that they were learning new skills in quality improvement.
We all listened to each other's input, and I think it meant that the project was a lot more successful because you had lots of ideas coming from different sides.
The more senior clinicians, so the consultants supervising these doctors, often didn't have the skills or knowledge or learning of quality improvement either. So, you know, we're all learning together.
Over time, so you've got your outcome. So instead of audit, you kind of make these recommendations. They're implemented over the next month or year, and then you re-audit.
We've learned that this sort of approach in quality improvement fits very neatly with our core aims to improve quality of care for patients. We've learned that it can be fitted well into a junior doctor training programme. We've learned that there isn't a conflict with clinical audit, that the two are complementary. And we've learned that it's practical to do.
We have a changing healthcare environment, and it's really important that as physicians in the 21st century that we're able to respond to that.
If we can train a cohort of people who have the skills and have the experience of having done it at this level, at junior doctor level, then they will enthuse colleagues and friends around them, and they will grow through the system.